This podcast is being recorded on the land of the Bunurong people of the Kulin Nation. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This episode is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced and evidence-based discussion. When medication is mentioned, we'll use the generic name, unless referring to a specific medicine listed on the PBS, in which case we'll use the commercial name. Please note, medication availability can vary between Australia and Aotearoa, New Zealand. Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest RANZCOG guidelines and RANZCOG research through in-depth conversations with leading experts in obstetrics and gynaecology from Australia and Aotearoa, New Zealand. I'm Associate Professor Scott White. I'm a maternal fetal medicine specialist based in Perth, Western Australia. In this episode, we're turning our focus to the updated RANZCOG guideline on early pregnancy screening and the prevention of preterm preeclampsia. This condition, while uncommon, carries significant risks for mother and baby, especially when it develops early in pregnancy. Joining me to unpack the guideline are two expert clinicians, Professor Amanda Henry and Associate Professor Daniel Rolnik. Before we dive in, let's hear more about each of you. Amanda, we'll start with you.
Great, thanks, Scott. So I'm Professor Amanda Henry. I'm a clinical academic and obstetrician based in Sydney and the program head for women's health at the George Institute for Global Health and Professor of Obstetrics at the University of New South Wales. I'm also a current RANZCOG counsellor and the Deputy Chair Obstetrics of RANZCOG's Women's Health Committee, and I've been involved in preeclampsia research and clinical care throughout my career.
Yeah, thanks, Amanda. Daniel?
Thanks, Scott. I'm Daniel Rolnik. I'm an obstetrician gynecologist at Monash Health, and I'm also an associate professor of obstetrics and gynecology at Monash University. And I was a member of the guideline development group that produced the guideline that we are discussing today.
Right, thanks both for being here. Before we get into our discussion, could I ask you both to declare any relevant conflicts of interest?
So I was a member of the working group and one of the co-authors of the 2023 SOMAN, so the Obstetric Medicine of Australia and New Zealand's Hypertensive Disorders of Pregnancy Guideline. This guideline is RANZCOG endorsed and it has a much broader scope about hypertensive pregnancy than the RANZCOG guideline we're discussing today, and there are areas of overlap and maybe we might discuss those a bit later in the podcast.
Great, thanks. Daniel?
Yeah, and I have no conflicts of interest, Scott.
Great, thanks. Let's begin with some background information, Daniel, why this guideline was updated, and can you tell us why the focus specifically is on preterm preeclampsia?
Yeah, so the idea of the guideline was to refocus and strengthen some of the recommendations to align with current evidence and some of the large studies that came out in the last few years, align with best practice and what we now consider standard of care. We also want to allow for better clinical utility of first-trimester assessment and trying to see patients early and assess risks properly in the beginning of the pregnancy. The focus on preterm preeclampsia was primarily because we have a very effective intervention to prevent the disease. We know that there is no cure for preterm preeclampsia. Basically, we need often to deliver the baby prematurely. That's often required to keep the mother safe and the baby safe. The intervention being very effective to prevent these early and severe forms of preeclampsia would have a very big impact on outcomes for mothers and babies we look after. And there is a growing evidence for early prediction and prevention of preeclampsia, and we wanted to align the guidelines with this best evidence that we have.
Now that we've covered the rationale, let's turn to the timing of screening. Amanda, the guideline highlights the first trimester, specifically between 11 and 14 weeks, as the ideal time for screening. Can you explain why that window is so critical and what happens if clinicians miss it?
So that window is because it is the optimal timing for using the model that combines maternal history, mean arterial pressure, ultrasound, including the uterine artery pulsatility index, and the serum markers, the blood biomarkers. And those biochemical markers like the PAP-A, pregnancy-associated plasma protein A, and placental growth factor, PLGF, are the most predictive at this stage. And then very importantly, it enables the timely commencement for those women who are identified as being at high risk of prophylactic aspirin, so to prevent preterm preeclampsia. Unfortunately, if we have later screening, then that misses that intervention window in terms of optimal preterm preeclampsia prevention. And I think just another sort of general point to make about that earlier 11 to 14 week screening, although it's not the specific focus of this guideline, getting women into comprehensive pregnancy care by the end of the first trimester is important in terms of all sorts of pregnancy outcomes, optimising pregnancy outcomes generally. So 11 to 14 week preeclampsia risk assessment's part of that.
Yeah, it fits in really nicely, doesn't it, with that concept that the interventions that we have to improve pregnancy outcomes generally start quite early in pregnancy, and we can set someone on the path to a good pregnancy from early on, and this fits well within that, doesn't it?
Absolutely.
Let's look at the clinical tools that clinicians have for assessing risk. So, Daniel, what makes the Fetal Medicine Foundation first trimester, the FMF screening algorithm, the recommended approach over the more traditional history-based assessments?
Yeah, so before we talk about the model, the Fetal Medicine Foundation model itself, let's just understand a little bit how risk factors work and what we've been doing for decades. For decades, we've been using checklists of questions that we ask all pregnant people in the first trimester or the first antenatal visit. And it's basically a yes or no approach. So we ask questions: if you are older than 35, you are high risk; if you are younger than 35, you are low risk, and so on. It's a very simple approach, and we tend to like it because it's very easy to do, but it doesn't work very well. So there is nothing magical that happens on the night you turn 35 that you become high risk. And there is good research now, very large studies showing that this type of approach essentially miss about 70% of women who have preeclampsia. So the detection rates are quite low. We label about 10% of the population as high risk, but we detect only a small minority of those who have preeclampsia. So it's a simple method, but it doesn't perform very well. What the prediction model does, the Fetal Medicine Foundation prediction model does, is take into account all those characteristics in a continuous manner rather than dichotomized at a specific cutoff, and then combines that with biomarkers that have been shown to differ in people who develop preeclampsia compared to those who do not. And then we can actually provide each person now with their own individualized risk assessment. So you can tell someone, your risk is 1 in 5, which is very high, 20%, or your risk is 1 in 1,000, very low, go home and enjoy your pregnancy. And when we do that, we more than double the detection rate. So we now detect 3 out of 4 patients who have preeclampsia very early, before 37 weeks. And that is what makes this model a more sophisticated, individualized approach that allows us to detect a lot better and clearly outperforms this kind of checklist approach that we spoke about. The other interesting thing is that if you have a low risk result from this screening test, even if you have risk factors, but you happen to have a low risk result, it is very reassuring that the chances you develop preeclampsia are very, very low. So even if you have risk factors, even if you are 40 years old, even if you have chronic hypertension, but you happen to have a low risk result because your biomarkers were very good, you can reassure people that the risk of preeclampsia is very, very low.
It's a great screening test, isn't it, where it has that good balance of sensitivity, detection rate and specificity, and really reassuring the normal people that they are really low risk and correctly identifying a high proportion of those who are at significant risk. Let's talk preterm preeclampsia prevention now, specifically, Amanda, the role of aspirin. So aspirin's highlighted a key part of prevention in this guideline. What does the evidence tell us about the ideal dose, the timing of aspirin therapy, and how does that translate into clinical practice?
In terms of the dose and the timing, essentially the guidelines saying aspirin at or above 100 milligrams and started before 16 weeks reduces the risk of preterm preeclampsia, so preeclampsia onset before 37 weeks. Unfortunately, we haven't yet come up with anything that can reliably reduce term preeclampsia, which it should be acknowledged is still the most common form of preeclampsia and affects the most pregnancies. The greatest benefit with aspirin is seen in the sort of the early onset preeclampsia, so preventing preeclampsia before 34 weeks gestation. The Aspire trial would say you might be able to prevent up to 90% of before 34-week onset preeclampsia with institution of aspirin by 16 weeks. The ASPRO trial would also say that higher doses, we've said sort of 100 milligrams and above in RANZCOG, but sort of I guess the biggest randomised trial on this, ASPRO would say used 150 milligrams as the dose, and that may offer added benefit. In terms of that timing, we do know that starting aspirin after 16 weeks, unfortunately, is less effective, and that's likely due to the timing of placental formation and what's going on pathology-wise and what aspirin is doing. So we know that preterm preeclampsia is strongly associated with impaired placental development early in pregnancy, instead of the usual conversion from the sort of low-flow, high-resistance placental circulation to a high-flow, low-resistance placental circulation. That mechanism's impaired in preeclampsia. And we think that aspirin has both anti-inflammatory and antiplatelet effects on placental development. But obviously to be effective, you have to start it while that development is still very much still underway, so before 16 weeks. The other point to make, so once daily dosing, but that dosing ideally is in the evening. That may also improve outcomes. Again, and I must admit, I have to look this up every time, the mechanism as to why the nocturnal aspirin is better. But essentially, aspirin's influence on the angiotensin II and renin pathway is most active at night, and so that's why we think it's better at night.
Great.
And Scott, if I can just complement what Amanda said, the initial studies really were very controversial about whether aspirin worked or not, but we have to acknowledge that those studies gave very different doses of aspirin, started at very different times during the pregnancy, looked at different outcomes, defined preeclampsia in different ways. And then in the early 2000s and 2010, a series of studies started to show that probably we should give at least 100 milligrams of aspirin, and we should start early, before 16 weeks. Aspirin was much more effective to prevent early preeclampsia, but not so much late preeclampsia. And that's why when we did the aspirin study, we decided to go for a slightly higher dose of 150, which seems to be the ideal dose for most people. And we wanted to couple that with a good screening test at 11 to 14 weeks and start at that time, on that day of that assessment, to maximize its effect.
Yeah, I think while we're talking about the ASPRO trial, we probably should acknowledge, Daniel, you're the lead author on that study, but that clearly was the landmark, the Sentinel trial, that showed that screening and then identifying high-risk women, starting them on aspirin, was hugely effective in the prevention of preterm preeclampsia and really led that drive for clinical implementation.
Yes, but perhaps the most innovative part of the aspirin trial was the screening method. So we really used an effective screening test to identify high-risk population that should be targeted rather than using just risk factors, which is what previous trials had done.
What about calcium? The guideline highlights it as consideration in some cases. When should we use calcium in addition to aspirin?
Look, I do think it's fair to say there is a little bit of controversy about calcium supplementation, Scott, and I know both RANZCOG in this guideline development and also SOMATS, we've kind of tossed it back and forth. And the reason for that is sort of potential small study bias in the trials that have been done. So the trials that most strongly seem to demonstrate a benefit of calcium in lowering preeclampsia rates are reasonably small, and the largest randomised trials, which tend by their nature to be more transparent, less open to various biases, haven't really shown that strong effect. However, look, particularly in women who have low dietary calcium intake, then supplemental calcium may well reduce the risk of preeclampsia. And for those that are unsure about dietary calcium and whether the woman's intake is adequate, there are calcium intake calculators actually readily available to help estimate it quickly. If you're going to be looking at calcium, the recommended dose is more than 1,000 milligrams a day. So, for example, in Australia, that would be sort of 2 600 milligram tablets. It is also, I think, in a practical point of view, worth acknowledging these are large tablets, and so they may be difficult for women who experience nausea and vomiting in pregnancy or those who have trouble swallowing pills to take. And really important to say, calcium should always be used in addition to aspirin. It is not a replacement.
Let's shift to some of the real-world challenges that us clinicians on the ground face. Amanda, what are the main barriers to putting this screening approach into practice, especially for clinicians in remote settings where resources are often limited? How does this guideline suggest we address those challenges?
Yeah, look, there's no one magic silver bullet to this, and I think it is worth stating up front that at this point in time there is limited access to the early ultrasound and biochemical testing that we require in order to, fully implement multimodal screening, and also really importantly that even when it's available there are usually still out-of-pocket costs for patients to doing this testing because it is not yet covered either in Australia or New Zealand in terms of federal government rebates. And then, as you alluded to, once you're outside sort of metro Australia or Aotearoa, then you may not have access to that placental growth factor testing or the specialised ultrasound in terms of uterine artery pulsatility index. And so I think it's also worth saying that it's not just everybody who can do this ultrasound. You do, just as we have kind of quality control for the various biochemical markers, you absolutely need quality control for the sonographer and sonologists who are doing the uterine artery Dopplers, because garbage in, garbage out, unfortunately. Yeah. I think the other thing is even when the tests are accessible and affordable, delayed presentation to care is a reality for a lot of our pregnant population, particularly in resource-limited settings, and so that makes early screening, more difficult. In terms of what can we do? So, as Daniel alluded to, clearly, maternal history alone is inferior, but even partial implementation of those screening strategies. So if you do the maternal history and you can at least get a maternal arterial blood pressure, that, gets you a reasonable amount of the way there. If through first trimester screening you've got access to the PAP-A, that also helps. So that still improves our ability to identify those at the highest risk of preterm preeclampsia, even if it's not the full model. Obviously, importance of provider education, which I guess this podcast is part of, and support at a systems level. And then, look, obviously, we do need to be realistic about our strategies for regional, rural, remote settings and trying to reduce those health inequities, address those practical challenges and advocate to improve outcomes in our underserved communities.
Yeah, and Scott, just to complement that, I think that's very important to highlight. The previous screening tests we had or models, first, were not well validated as this one is. But second, this one is a much more flexible approach. So even if you were just to take the history and put it in the calculator and use age and weight and height in a continuous manner in the calculator and put the blood pressure there, we would already be doing much better than just using those checklists that we spoke about before. So there is a trial now ongoing in Africa where they are only using history and mean arterial pressure, and it's performing quite well because it's a very high risk population. It's a very high prevalence region of the world. So even if we use partial combinations with whatever is available to us, we would be doing much better than just using yes or no risk factors. Yeah. But it's what Amanda says is important. It's very important to have a quality assurance process in place when we go for this type of screening test. Yes,
really important points on it. I think if you're going to do, the partial components of the algorithm, important to enter them into the web-based calculator, which is freely available, rather than considering those risk factors in isolation where your test performance characteristics really aren't as good as the published data. We'll be back with more after this quick break.
Did you know RANZCOG has released the Australian Living Evidence Guideline Endometriosis, a fully updated clinical resource which will improve care for women and people living with endometriosis. Find out what's changed in diagnosis, treatment and management, including deep endometriosis is visible on ultrasound if you look for it. Physiotherapy and psychology treatments work. The guideline also includes a summary flowchart highlighting the care and management pathway of people with suspected or diagnosed endometriosis. A quick reference guide has been developed for GPs in primary care, and there are also new resources available for the public. The Living Evidence Guideline brings together the latest research with clinical expertise and lived experience to ensure care providers have access to reliable, up-to-date information. Explore the new resources on the RANZCOG website. Visit ranzcog.edu.au/endometriosis.
Welcome back. We know not all pregnant patients will present early for antenatal care. If some show up after 16 weeks and haven't had that screening in that 11 to 14 week window, what should clinicians do, Daniel?
There are similar approaches using a calculation for individualized risk assessment that have been developed in other gestational windows. And these essentially align with many of the ultrasound windows we have, so 11 to 14 weeks in the first trimester, 19 to 23, 24 weeks in the second trimester, and then later in the third trimester. They are slightly different calculation formulae, but they all follow a similar approach. The biomarkers also change, and the weight of the biomarkers also change as gestational age changes. If a patient comes to us too late, one option would be to do the test at 20 weeks when they have their mid-trimester anatomy scan. But the problem we have is that, as Amanda mentioned before, aspirin is not as effective when started late after 16 weeks. So there is a lot of discussion about whether we should still prescribe aspirin to someone at high risk at that stage. Very often after 14, 15, 16 weeks, we use risk factors alone. There is still a lot of discussion about starting aspirin at that stage is of benefit or not. Those would be the two options. One would be just to go by risk factors if they miss the 11 to 14 weeks window, or wait and do slightly later a similar approach, but in the mid-trimester.
And I guess although we can't then offer treatment because the treatment's less likely to be effective, maybe our antenatal care might then shift away from prevention towards monitoring and early recognition of those women who do go on to develop
and that
disease.
is also important, to try and tailor the antenatal care model and frequency and intensity based on the information we have on risk. So despite the fact that prevention may not be so effective at that stage anymore, we still can have other things and have close monitoring of people identified at higher risk.
Yeah, and look, I think we should probably, inject a bit of pragmatism here at this stage as well, just as you were saying before in terms of, say, maternal age, Daniel, and there's nothing magical that happens between, 34 years and 11 months and 35 years. There's probably nothing magical that happens between 15 weeks and 6 days and 16 weeks. So if, on history and with maybe blood pressure as well, you've got a woman who you consider really high risk for preeclampsia, had baby at 30 weeks last time, or the blood pressure's near that 140/90 kind of mark and she's 16 and a half weeks. I mean, really, given that aspirin overall has a very low side effect profile, I think you would start, but knowing that obviously it may not be as effective. And that needs to be obviously shared decision-making, with the woman.
Yeah, I agree with you, Amanda. And I think what the studies really show is that the effectiveness is much less, but possibly there is still some benefit of starting aspirin late. So if you ask me what I do in my practice, when I see someone at 18 weeks who has had preeclampsia in 3 pregnancies before, yes, I put them on aspirin. And I think there may still be some benefit to that.
Amanda, the guideline, as all of our college guidelines do these days, places a strong emphasis on equity. What are the gaps we still need to address to ensure that care is accessible and culturally appropriate, particularly for Aboriginal, Torres Strait Islanders and Māori and Pacifica Islander women?
Yeah, thanks, Scott. Nice, easy question. Before I talk about equity, I think it's probably just worth touching on a couple of key concepts. So one of those is intersectionality. So the idea that people experience overlapping forms of either privilege or discrimination depending on factors like race, gender, your geography, your socioeconomic status. It's not just a woman or not, or a person of colour, those things sort of all can interlap and, lead to differing individual circumstances. And the other is cultural competence, which is about our ability to understand and respect and respond to cultural needs. That's more broadly. In the context of First Nations health, cultural competence is really a vital strategy for improving care and reducing inequity. So in terms of our gaps with preeclampsia, a really important thing to say is that we actually have disgraceful, really, lack of data on our priority populations in both Australia and Aotearoa, New Zealand. And one of the main gaps is that, we've got don't have access to comprehensive national data on preeclampsia rates in both Australia and New Zealand, and obviously need to be a focus of research moving forward, but we particularly don't have them on priority populations such as Aboriginal and Torres Strait Islander women. So also, of course, to say that the FMF algorithm isn't yet calibrated for use in these populations. So that's obviously a major gap that we need to address moving forward. What we do know from relatively smaller studies in Australia a few years ago, a higher rate of Aboriginal and Torres Strait Islander women diagnosed with preeclampsia, so about 3.5% compared with just over 2%. In Aotearoa, New Zealand, it's thought that for Māori and also for Pacifica women, the rates are also higher. That's going off data that's sort of more than 10 years old now, though. And then in terms of other priority populations, so migrant and refugee women, and, they kind of get lumped together, but obviously there are many different backgrounds that our migrant and refugee populations come from. And so the baseline risk of preeclampsia actually varies quite a bit depending on your country of origin. So migrants from Southeast Asia might actually have lower preeclampsia rates than Australian-born women, but as Daniel was just mentioning in terms of Africa and origin, usually much, higher rates. And then obviously regional and rural areas, and this is one of those areas where intersectionality really does become a consideration because, for example, in Australia, our Aboriginal and Torres Strait Islander women are also more likely to be living rurally and remotely. The LGBTQI plus people, so rates of preeclampsia are probably higher in those same-sex couples where assisted reproduction is being used because we know that's a preeclampsia risk factor. And for pregnant people, so those who are pregnant who don't identify as women, this may also be the case, but we really just don't have the data there at this point.
Yeah, but it's important to keep in mind, Amanda, that a lot of this data is relatively recent.
Yes.
So really, the strength of the data only came out in the last 10 years or so. And it's going to be up to us to do those studies now and make the adjustments that are necessary in our population. We all know a colleague of ours who has been flying to remote communities in Northern Territories and applying the full Fetal Medicine Foundation algorithm to remote communities. So it can be done, but it's going to be up to us to collect data and make the adjustments we need to make.
And I think it's also important to say in that research moving forward, that data sovereignty and working with our priority populations, not on them, is hugely, important.
Yeah, absolutely.
Amanda, can you talk us through some of the barriers that these populations face and what the guideline recommends as pathways towards culturally appropriate care?
Yeah, so barriers are probably quite similar in both countries. Obviously, one big one, which we've kind of already touched on, is delayed antenatal engagement. And there's a few factors for that potentially, one being regional location for many, and so a lack of easily accessible services, having family and other caring responsibilities, then a lack of culturally appropriate care, leading to patients feeling unsafe interacting with the medical system. And so that can be both a reason to delay your pregnancy care and also a decreased engagement with it even once you do present. And we shouldn't underestimate the cost of care, both getting to care in the first place and various out-of-pocket expenses for many of our priority populations. So, that includes regional and rural patients, migrant women, many of whom in, the first few years of their migration journey won't have access to Medicare, never mind sort of out-of-pocket costs for the multimodal tests. It's costing them to get to appointments and to have those appointments in the first place. In terms of, how do we chart a path towards culturally competent care to help break down some of these issues? So clearly, obviously, we need to have inclusive and culturally safe models of care and multidisciplinary teams that work with members of community. We do, as we've kind of already discussed a little bit with Daniel, need further evidence-based research to, better understand these populations. And also just important to say, the guideline does include a Māori equity toolkit in terms of assessing barriers that Māori women face in particular and to help inform culturally responsive approaches.
Daniel, our guideline recommends stopping aspirin at 36 weeks. Can you explain why? And is there room for clinicians to use their judgment here?
The timing of stopping aspirin is a very big question that I don't think has been well answered yet. We don't really have good data to guide us there. The initial concerns many decades ago were that aspirin first could potentially cause malformations, but this has been debunked now. We know that aspirin does not cause malformation from very large studies. But the other concerns were that aspirin could potentially cause premature closure of the ductus arteriosus, which has also now never been proved by randomized trials. And there are some observational population studies, mainly coming from the Nordic countries, suggesting potential increases in bleeding, so intrapartum and antepartum hemorrhage, and potentially bleed for the baby postnatally. But again, this data comes from observational studies that have methodological problems. They are not randomized trials. And for those reasons, when we did the aspirin trial, we decided to stop at 36 weeks. Most of the previous randomized trials stopped somewhere between 34 and 36 weeks. Now, there is a recent randomized trial that came out from Spain suggesting that possibly we could stop it at 24 to 28 weeks. We have shown also that most of the changes we see in biomarkers in people using aspirin happen in the first 20 weeks of pregnancy. But that study from Spain also had some methodological issues, and I don't think we have the final answer yet. So for now, I usually continue aspirin until 36 weeks, but definitely there is room for clinical judgment, and you need to discuss that with your patient. And if they develop other complications that may require delivery, we may need to stop aspirin a little bit earlier than that.
And I think it's probably worth adding as well, Daniel, that as you say, although the Scandinavian Nordic sort of studies did show that there was some increased, risks of aspirin in terms of bleeding, it took a population study to do that. This was like a huge database to show that. And the individual, randomised trials, including Aspray, sort of haven't, suggested that risk. So
yes,
it is small, likely small.
Yeah, there are a few problems with these population studies. First is that because the intervention is not actually randomized, people who are on aspirin tend to be at a much higher risk of many complications than those who are not. There is a reason why they have been given aspirin. And then they define aspirin use as the intake of at least one tablet of aspirin during the pregnancy, which is also problematic. So if you take aspirin for a headache, you fall into the aspirin group and so on. So there are some methodological issues with those studies. And randomized trials on targeted high-risk populations have not actually confirmed those.
I mean, I think it's probably the bottom line is the population study is an argument to not give aspirin to everyone, but it should absolutely not deter clinicians or women from starting it for valid reasons and continuing.
Yes, I agree. And the argument of giving aspirin to everyone has come up recently, and I've always been against that because I think if there are any side effects that have not been proven in trials, we would exponentiate that by giving aspirin to millions of people who don't need it. Preterm preeclampsia is a relatively uncommon condition. So by definition, it would be treating 98 to 99% of the people unnecessarily, and compliance would likely be very low because without targeting a high-risk population, most patients would not take it.
Amanda, you mentioned earlier that you're involved in the SOMANS guideline released in 2023, a broader hypertension in pregnancy guideline. I'll give it a plug. Anyone who's not seen it should. A really high-quality NH&MRC endorsed guideline that tells us a lot about the management of hypertension in pregnancy. Can you talk us through some of the key differences between that SOMANS guideline and the new RANZCOG guideline?
Thanks, Scott, and thanks very much for the plug. Look, I should also emphasise up front, so these are not competing guidelines. Yes, RANZCOG has endorsed the SOMANS guideline, as have other major bodies, including the Australian College of Midwives and the National Health and Medical Research Council. So yes, there are different purposes. So the SOMANS guideline is broader. It's covering all hypertensive disorders across pregnancy, not just preeclampsia, and it also includes, the postpartum journey as well. Whereas this RANZCOG guideline is specifically focusing on screening and preventing preterm preeclampsia by, screening early in pregnancy and instituting prevention. So there is obviously, though, a screening and kind of prevention overlap, and within the shared focus on early risk assessment, I suppose some key distinctions. So RANZCOG strongly recommends the FMF multimodal screening algorithm. SOMANS absolutely acknowledges the algorithm's value, but is a bit more cautious, noting that absolutely what they say in the guideline may change as the evidence continues to evolve, but sort of wanting a little bit more validation first. But absolutely both guidelines support early screening and aspirin prevention for those at high risk of preeclampsia. And SOMATS absolutely also does note that where, there is access to the full model, that is, clearly superior to history alone. I guess there's also, equitable access remains a challenge. And look, I think probably both guidelines acknowledge that. And of course, government funding of the FMF screening could reduce the out-of-pocket costs and considerably improve uptake. In terms of the aspirin recommendations, so SOMATS is kind of going with 150 milligrams at night, aligning with Aspray, whereas RANZCOG's got a little bit more give, says, 100 or more, noting that the 150 milligrams may be more effective. Then other things I just want to give a plug for here. SOMATS talks about, along with aspirin and then potentially calcium, exercise as a third strategy for preeclampsia prevention. Now, the evidence for this is not high level, but case control and cohort studies do suggest that moderate aerobic exercise from early pregnancy may reduce the risk of hypertensive disorders broadly, not, just preterm preeclampsia. So that's why, RANZCOG didn't have a focus on it. It's not specific to preterm preeclampsia. I think it's also really important to say, pregnant women don't need to take exercise seriously. They just need to take it regularly. So, 150 minutes or more a week of moderate activity like brisk walking, swimming, cycling, and as well as the potential benefit on blood pressure in pregnancy, also lowers your gestational diabetes risk, good for mental health and just for general fitness. So, and I guess then in terms of other differences, in terms of equity, RANZCOG's got that, including practical tools like the Māori Equity Toolkit. SOMATS does address equity within its evidence to decision framework. That was an inbuilt part, and we have translated the patient information into multiple languages, including Māori and the most commonly spoken languages in Australia, but it doesn't have that dedicated equity section like RANZCOG. But look, I think we both acknowledge these are really important considerations. And in terms of position in the care journey, as we've said, the RANZCOG guideline is very focused on that early identification, prevention, and SOMATS is meant to be and hopefully is a more comprehensive resource to support clinicians and women and families across the pregnancy, birth, and postnatal period journey. Yeah.
Before we wrap up, I'd love to hear your key takeaways. What are the main messages you would like our listeners to walk away with? Amanda, let's start with you.
Okay, so get pregnant women into care early, screen for their preeclampsia risk, and start aspirin by 16 weeks if they're high risk. This is a prevention success story. We just need to implement it well. And don't forget the simple stuff. Regular exercise not only helps prevent hypertensive disorders, it also supports overall physical and mental health.
Thanks. Daniel?
Yeah, so my key message is I think what we've been doing for decades is very simple and it's better than nothing, but it's ineffective. We now have a much more sophisticated approach that will allow us to give each patient their own risk. We have a very effective intervention that prevents about 60% of the preterm forms of preeclampsia and 90% of the very early forms of preeclampsia. And although these are less common, they are highly associated with morbidity for mothers and babies, so it's important that we tackle them. As we mentioned a few times in this podcast, even using partial forms of the algorithm would do much better and is probably the way to go in under-resourced settings. As Amanda mentioned, the importance of getting people to us early, if we are to implement this kind of screening test, then we need to do a lot of work still to educate patients, to work with GPs. It's a very important part of this implementation will be to work with GPs and make sure people get to us early. It's very easy to do, but we need to see pregnant women early. I think we are doing a lot better now than we were a few years ago. The numbers of women who we see at 11 to 14 weeks now, at least in my hospital, have increased significantly, but it's still not ideal.
Amanda, Daniel, thank you both. This has been a really practical and insightful conversation that hopefully our listeners will get a lot out of, so thank you again. If you found this episode valuable, don't forget to rate, review and subscribe wherever you get your podcasts. You can also log this episode for CPD hours. Just check the show notes for the link to the CPD form, along with a full RANZCOG guideline and other helpful resources. Thanks for listening. We'll be back soon with more expert insights on Talking O&G.